conferences and all, the way he used to deliver the lectures and teach the students, and we all used to learn a lot from him. Let me start with a invocation to all the teachers in this audience and also my teachers. Guru Brahma, Guru Vishnu, Guru Devo Maheshwaraha, Guru Sakshat Parabrahma, Tasmai Sri Guruve Namaha. With this invocation, I would start my lecture. All of you know Professor Phanindranath Thota. He was born in 1951 and passed away at a tender age in 2004. He has achieved so much in the short period of time. The Indian Journal of Anesthesia, in its obituary, has summarized as, never has the profession seen such an individual, and one will have to wait a long time for such an individual to come again. He was born in Andhra Pradesh and he did his MBBS from JIPMER. He has a fantastic academic career. He did his MBBS from JIPMER, Pondicherry. He has done his postgraduate from PGI Chandigarh and also worked at Sri Chitra Institute, Trivandrum. And for 21 years, he was part and parcel of the KMC, Kasturba Medical College, Manipal, where they used to conduct an annual update, the CME program, which used to be a very eminent scientific program in the Indian calendar. Later, he came back to Andhra Pradesh and worked in Vijayawada and Kakinada.
Two very eminent
Between
scientific
2001
programs
and
in the
4,
Indian calendar.
I had a
the
great
Science
opportunity
Congress,
to
typically early
meet him
January.
at various CMEs, especially at
February
RACE in
28th.
Ramchandra. We used to
Additionally,
interact a
the
lot.
All India
I
Cell
used to
Biology
faculty and
Conference and
always
Symposium.
keenly listen to him. And also, to my fortune, one of his relatives was admitted in Vijay Hospital during 2002, and he was there with me for 3 days. He was so enthusiastic. He came to our theatre. He was spending time with me in the ICU. He was so inquisitive about everything. He was asking me so many things, so many questions like a student. I think that's what greatness of Dr. Phani. He never stopped learning and he always used to share the knowledge. That's a wonderful interaction I had and I cherish it forever. And many of his students have been my good friends. So one of his students, I asked him, you described Dr. Phani sir.
PH.
So Dr. Mahesh Wakamudi, one of my good friends and his close student, he said, beyond being an anesthesiologist par excellence, he is truly an adorable human being and we will remember and cherish him and follow him forever. This is the greatest tribute a student can pay to his teacher. I would like to have the pointer. So, anesthesia safety used to be a topic which is very close to Dr. Phani's heart. So, when I was asked to deliver this lecture, I was thinking what way I can pay a good tribute to him. So, I thought I'll choose the topic of enhancing anesthesia safety, challenges, strategies, and innovations. Before I go to the topic, let me pay my tribute to my teachers. In the center is Professor P. Gopalakrishna Garu, who has been HOD when I was doing my post-graduation at RMC Kakinada. And to the right is late Dr. Raghavendra Rao Garu. I learnt a lot of anesthesia and also life lessons from him. Other one, Dr. R. Rangarao Garu. He was instrumental in pushing me to Chennai. He said, you should not be practicing at Kakinada. You please go to Chennai, learn cardiac anesthesia. Of course, another two forever young gentlemen who have always been inspiring me and also teaching me. That is Dr. Chakkarao Garu and Kameshwarao Garu, who have played a great role in the ISA, in the build-up. Fantastic organizational people. I salute to them, especially Dr. Chakkarao Garu for taking forward the Indian Resuscitation Council and doing a human service to the specialty of anesthesia and also to the public. And after I left and joined Apollo Hospital, I had my mentors who have been this is Dr. I.S. Naidu, one of the very senior cardiac anesthesiologist, fantastic anesthesiologist, and I'm proud to say he's also one of the richest anesthesiologists of the country. Other one, Dr. Bhaskaran, who always used to talk about safety of the patient. He taught me the ABC of cardiac anesthesia. This is Dr. Girnath, one of the most eminent cardiac surgeons of this country, who has done about 50,000 cases. I joined his team. He's a great human. See, he always used to talk about patient-centered care. That's what I always used to think about the safety and all. Being a cardiac surgeon also, he used to respect the anesthesiologists. He used to always inspire us. Other one on the top is Dr. K. Reddy, is a cardiologist. This is Dr. Janardhan Reddy. We three of us are working as a team for last 30 years. And always our approach has been for ethical practice, and I learned all that from them, and to how to deliver a safe patient care. So coming to the topic, enhancing anesthesia safety. Coming 30 minutes, I am going to deal with this topic under these following subheads. Why is anesthesia safety important? What is the extent of problem? Where we have been and where are we now? What are the innovations which led to current level of safety? And what are the common errors and mistakes during anesthesia? Especially I am going to focus on the human errors and how can we overcome them? That is about the safety culture. And what does the future hold for our specialty? That is role of technology. And then later I am going to summarize and few take home points. Coming to why anesthesia safety is important. It is very essential for surgical success. There is no successful surgery without a safe anesthesia. And any anesthesia complication can be disastrous, like a Air India accident recently we have seen. It hardly gives very little time to react or to correct. Like that pilot hardly had few seconds to realize what is happening. And very aptly, this is from the heading of Times of India. One day after this accident, between the takeoff and landing is the story of our lives. If you compare with anesthesia lives, each induction of anesthesia is a takeoff, each extubation is a landing. So that is the story of our life. How many hundreds of safe deliveries, safe anesthesia we have done? One disaster is enough to finish us. One disaster is enough to finish that family. So that is the importance of anesthesia safety. That is why I have chosen this topic. So it gives very little time to react and correct. I have, as a cardiac anesthetist, I have seen holes being made in aorta, but still we get a time. But a misplaced tube will hardly give you a time. So that is the importance of safety of anesthesia. You all know it's not, surgical complications are to some extent accepted by the patients, but they are never accepted by the anesthesia complications are not accepted by the patients. And surgeons are like wives. They will never forget your complication. Decades later, they recollect you. They say that day you created a pneumothorax, that day you created a hematoma. So my surgeon always reminds me, 20 years back some hematoma I created. So that is the thing. Surgeons are never forgiving. So their complications we have to carry, but they will never forgive our complications. And for hospital administration, we are not direct revenue generating. So they always look for alternative. The minute something happens, they conduct a big inquiry, audits, and then they say, oh, we have to get some better anesthetist. And nowadays courts are not at all considerate. Any anesthesia complication, very, very heavy damages are being awarded. So one case can finish your entire earnings, lifetime earnings. So we all have to be careful about it. So anesthesiology, all of us know, have undergone remarkable evolution and a revolutionary process. Without advances in anesthesia, surgical advances would not have been possible. The specialty of anesthesia has reached this stage thanks to pioneers who have contributed to important improvement in anesthesia techniques like introduction of new anesthetic agents, precise administrative methods, secure and reliable monitoring technologies, and creation of professional associations like Dr. Bala Venkat was talking about ISA and FSA. So these associations have played enormous role in contributing towards the improvement of the specialty. Same way, establishment of national and international guidelines also are helping to deliver a safe anesthesia. All these steps have revolutionized the contemporary medicine, allowing quality surgery to be done and complex intervention to be done with significantly reduced risks. As a result, in the 1940s, the mortality used to be like 6.4 in 10,000 operations, whereas by the time we came to 80s, it is 0.4 for 1 lakh operations. Today, the risk is even lower, especially in advanced nations. There is 1 death for every 2 to 3 lakh operations, but in lower middle income countries and in setups where there are limitations in the infrastructure, the 1 in 133 patients may face some complications, if not mortality. So,
introduction.
So we should know where we have been and where we are going. What are the important steps happened is the evolution of anesthetic agents, development of anesthesia administration technologies, and revolution of the sophisticated equipment have happened. All these have made anesthesia as a leader in patient safety. These are all the technological advances which happened in last 40 to 50 years. So coming to the technological advances, we all should say it is the invention of pulse oximeter which had made a paradigm shift in the safety of anesthesia. This people like us and who are sitting in the front row, the senior anesthesiologists, can realize because we have given anesthesia without pulse oximeter. Now we know what is its role and how it made the anesthesia safe. Other important discovery was usage of capnography and various hemodynamic monitoring technologies like the arterial line invasive and then CVP, PA catheter, cardiac output monitoring, and also non-invasive hemodynamic monitoring, neuromonitoring like BIS, NURSE, and all these made a huge difference to the patient safety. Anesthesia machine, we all know, we have started with Boyle's machine, many of us. Now we are having a very safe workstations. Same way, many new drugs and therapies have come, and all of you know about the role of imaging in anesthesia. More and more, we are doing TEEs, we are giving the ultrasound guided blocks, and we are putting central lines with ultrasound guided approaches. And pain therapies are also done using the ultrasound and other innovations. You know what is the important role ultrasound is playing in anesthesia. It is making us safer and safer. Same way, airway devices like video laryngoscopes and supraglottic devices also have made anesthesia much safer today. Drug delivery systems are also contributing to a big role for the advances in anesthesia. Other important thing is introduction of internet, computers, and even smartphone is adding to the technological advantages in these years. So coming to the next thing, development of new drugs. When we started as a postgraduate in late 80s, we used to have only morphine, pethidine, and pentazocine. Later buprenorphine came, tramadol came. Now we have fentanyl and remifentanil. Same way induction agents, we all started with thiopentone, then went to added ketamine. Now we use only propofol and etomidate. Same way, lot of developments have come for inhalational agents. When I was a postgraduate, I have not seen chloroform being used, but we used to use ether, trilene, and halothane was our go-to anesthetic. Later, my thesis was on isoflurane, and later sevoflurane, desflurane came. Nowadays, we don't use any of the above agents except sevoflurane and desflurane. Coming to muscle relaxants, we started with chibocurarine and saxamethonium. Galamine used to be the commonest non-depolarizer. Then we moved to pancuronium, vicuronium. Now we use rocuronium and cisatracurium. Same way, from diazepam we moved to midazolam, and we got now dexmedetomidine. Like this, also in the local anesthetics also, a lot of developments have come. which is adding to the safety of the patient. This picture, thanks to Chakravari, he has sent me the machine, Boyle's machine, which we used to use in late 80s with the ether and trilene bottles. I didn't have the picture, so I requested Dr. Chakravari. He sent me this picture some time back. So now, currently from here, I have moved to this workstations, and in our theatre now, this is what for major cases, this is what all the monitoring we do. This is the anesthesia machine. So we have come in last 4 decades itself, what I have seen, we have moved from a very basic anesthesia technologies to very advanced beat-to-beat cardiac output monitoring, this monitoring, and ETCO2 monitoring, and all these monitorings. So, have we reached the peak? It is widely believed anesthesia is much safer today compared to 40-50 years back. But although the anesthetics are not 100% safe, none of us can say that we are 100% safe. While much of the progress have been made, we still contend with baffling complications like malignant hyperthermia, anaphylaxis, air and fat embolism, drug overdosage, nerve injuries, epidural hematomas, post-dural puncture headaches. A lot of complications we do see. Errors, mistakes, and system failures continue to plague our specialty as well as other medical areas. Brain death, damage to brain occurs after hypoxia, even now occasionally. Complications often come from easily detectable and correctable events even when modern technology is there. Most basic standards are not followed uniformly. Dr. Bala Venkat was mentioning about it. In our own country, we have setups which have everything. We have rural setups and some government hospitals where all the facilities are not available, facilities are compromised. Clinicians still practice when they have fatigue, illness, and stress, prevent them from performing optimally. Knowledge levels and training of clinicians about equipment is still suboptimal. So, what are the common challenges? For the anesthesia risks, what are the major risks we are facing? Risks associated with the anesthesia procedure itself, the patient-related risks, and the risks associated with the healthcare professionals, that is the human factors. I am going to concentrate more on the human factors, and also what are the challenges specific to lower and middle income countries. Although modern anesthesia had made considerable progress, it faces complex and multidimensional challenges. One hand, we have risks inherent to anesthesiology, like the side effects of the drugs, like the bradycardia, hypotension of some of our drugs, and also complications like hematomas, complications like nerve injuries which can occur. And patient-related factors, we all know each patient is different, and their state of health, their medical history, their comorbidities are different, and also we know that there is variability of response from one patient to other patient. All these further increase the complexity of anesthetic management. So, what are the risks associated with healthcare professionals? We face significant constraints such as high workload, burnout, risk of legal action, limited resources. We all have shortage of qualified staff. Advanced simulation is available only for a tiny minority of anesthetists, and no certification requirement exists for continuing skill training and performance assessment. All these can impact the quality and patient safety. What are the specific challenges for lower and middle income countries? There are insufficient financial resources and infrastructure, shortage of qualified personnel and lack of motivation, fragile healthcare systems and inadequate healthcare provision, disparity and limited access to the anesthetic care, lack of continuing education. Many of the African countries and all, you don't even have qualified anesthetists to deliver the anesthesia. So, what are the current challenges? To summarize, we have the human factors of fatigue, overload, distraction and drug errors, and equipment failures like lack of equipment, and we all should know the limitation of the monitors. No monitor is perfect, we have its own And also we have the protocol gaps without SOPs, so we sometimes miss the comorbidities. Communication is very important, especially during handing over and taking over. Otherwise, wrong administration of drugs can happen. Complexity of the procedures and associated comorbidities are posing a challenge for us day to day. Coming to the human factors in anesthesia safety, I am going to talk elaborately about these factors. Why it is important in anesthesia? Because anesthesia is a high risk, time sensitive and cognitively demanding branch, and it has direct effect on the patient safety and team performance. All of us say, everybody says to err is human, but 70 to 80% of adverse events in anesthesia are related to human errors. And human factor approach shifts the blame from individual to systems, and it enhances this teamwork, communication and situational awareness. Coming to key domains of human factors, ergonomics, that is design of equipment and workspaces, also contribute to the safety of anesthesia. Communication is very important, not only within the anesthetic team, also with the wider surgical teams. Decision making, especially under pressure or when you are crisis, is also very important. Fatigue and stress, they impact on the attention and can lead to accidents. So as I was talking, what are the common human errors which occur in anesthesia? The commonest among the human errors is the medication errors, that is administration of wrong drug and wrong dosage. Other important thing is equipment mismanagement, either putting incorrect settings or missing the alarms. Same way, miscommunication also contributes to the human errors. About 25% of human errors are because of miscommunication during handing over or by writing unclear instructions. Same way, cognitive overload and fixation and failure to follow the checklists and protocols also add to the human errors during anesthesia. So coming to medication errors, you can see these are all not from net. My own anesthetic trolley I have taken out few months back and seen. See here, this one, calcium and aminophylline are looking so much alike, these ampules, and it is very easy to miss them. Same way, on the right side extreme, you can see one ampule is tranexamic acid, other one is nitroglycerin. Here if you see, one is heparin and other one is, what is the other one? Rocuronium, yes. Because what is happening, the same companies are manufacturing, taking these vials. So they are all looking very similar. This is rocuronium and this is heparin. Here, one is the dexamethasone, other one is the sugammadex. See, those two ampules are also looking. So it is very easy to miss out on those things. So coming to drug safety in operation theatre, we all should be aware of the look-alike and sound-alike drugs, and all drugs should be prepared and clearly labeled using pre-printed labels or handwritten labels. All drug infusions, catheters, infusion lines should be labeled. Each syringe should be labeled immediately after the drug has been drawn up, and prepare one medication and syringe at a time, and never put labels on empty syringes. All these are important precautions, especially for postgraduates, you should know. So, avoid distraction or interrupting others during preparation or administration of drugs. Double check if you are preparing a high risk medication. Cannula should always be flushed after administration of drugs. Many a times we give the drug, but we don't flush, so it doesn't reach the patient. Vials and ampules should be stored in the original packing, and anesthesia drug cards should be standardized. Throughout your theatre, you should have similar drug cards, and the trolley should be similar. Coming to work environment and workloads, impact of lighting, noise and workspace clutter also adds. See, many of our robotic theatres and the laparoscopic theatres, all the lights are switched off, so we hardly can see anything what is happening in the field. So there is an importance of lighting is there, noise and workspace cluster is also important. Importance of layout, monitor layouts, all the monitors we should be able to easily see them. And impact of long shifts and night duties we know. Most of the errors happen during night duties or post night duty when the anesthesiologist is working for long hours. There are more chances of missing out and committing more errors. Same way, mental workload and physical fatigue also contributes to the safety, breach in safety. So to mitigate all those, we should give adequate breaks, and we should be doing the vigilance, team-based vigilance, and we should distribute the workload properly among our colleagues. Distractions. This is one of the very common thing why errors can happen. We have lot of different types of distractions can happen. One is patient care related, especially when we are positioning a patient like a scoliosis patient. When we are trying to position the patient, all our concentration, everybody, all the anesthetists, all the team members' concentration goes on how to properly position the patient. Nobody looks at the monitor. That is the time we can sometimes have disasters. The tube can come out, or even the patient can develop a hypotension or bradycardia during that time, because that time even monitors are not properly connected to the patient. Next, coming to the technology, we all use TE in the operation theatres, especially cardiac operation theatres. We also use ultrasound, especially when we are doing ultrasound guided blocks and all lines. Our concentration goes on the images. Nobody looks at the monitor how the patient is. That is the time some disasters can happen. Same way, noise in the theatre and multiple alarms coming also can distract us. And personal distraction from devices. This is one of the most common thing. That is using the cell phone in the operation theatre. As per one study, actually it is as risky as seeing the cell phone and driving a car. Giving anesthesia when you are watching the cell phone is as dangerous as driving a car. So same way, distracted surgeon. Sometimes surgeon, because of his over enthusiasm, or sometimes he is not happy with something, he goes on shouting, and that distracts you from the patient care. And distractions in the perioperative period can adversely affect the vigilance, situational awareness, and ability to respond to changes in the patient's condition. All these pose a risk for the patient safety. Coming to the adverse events and near misses, this triangle is called the Hendricks theory. Here what happens is, well, in a organization there will be a lot of near miss events. Either we catch them in the last minute, or by luck sometimes it is detected. Like for example, in one day I asked for a calcium injection. My technician gave me potassium. How did I detect it? We have one protocol: 20 ml syringe will load potassium, 10 ml syringe will load calcium. He should have labeled it properly. The minute I asked calcium, he gave me 20 ml syringe. I saw it, I said, no, this is not calcium, this is potassium. So that is a near miss. That's a near miss event. So what is the other thing? So recently we had in our ICU, a patient was awake and he was moving his tongue. The tube came out, the anesthetist pushed it, it went into the esophagus. He didn't realize, but I was close by, I watched, there is no ETCO2, the patient saturation was dropping. That is what is called precursor safety event. So it happens event, but harm won't happen to the patient because somebody has corrected it. But a serious safety agent which reaches the patient, which may result in harm or death, that is a serious safety event. So for 300 near miss events, 30 precursor safety events happen and 1 serious safety event happens. So if we are able to prevent this by system corrections in our systems and our protocols, and we properly report these near misses and adapt our protocols to prevent such mishaps. A near miss today could be an accident tomorrow. So report all the near misses. We should encourage our staffs, our juniors, our colleagues to report the events. We should never punish for reporting a near miss event. That is where we can correct ourselves. So coming to other interventions, Preoperative briefing and checklists are very, very important, including the safe surgery checklist, on which side to operate. All these should be done meticulously. The checklist should never be tick list, because most of the time what happens, they tick all the columns, but you don't do a proper checklist. If you don't do a proper checklist, you can be going into leading yourself into a disaster. So it is very, very important to implement the checklist, so the errors will come down. And also, we should not hesitate to have our algorithms and emergency manuals in the theater. Suppose suddenly anaphylaxis comes. It is not the anaphylaxis, the panic following it kills the patient, because everybody runs helter-skelter. That is the time either a person who is senior should take the leadership, or they should have the emergency SOP, or how to deal with a patient who has got an anaphylaxis. So we should go as per the guideline. Same way, a patient develops ventricular fibrillation. So what are the things we are going to do? We should have those algorithms. I think Dr. Chakravarti is preparing all those algorithms. So standardized drug labeling and color coding is important. I used to remember when we were postgraduates, we used to have 3 drugs. 10 ml syringe is thiopentone, 2 ml syringe is choline, 5 ml syringe is pancuronium. So, but now with so many varieties of drugs, we can't have that type of things. We should have a clear color-coded labeling, and pre-printed labels are available. I think all of us should procure those pre-printed labels and use them. Same way, simulation is available. I think ISA is also taking steps to promote simulation to the postgraduates. I think that should be done, and also the crisis management scenarios can be practiced for the postgraduates and the practitioners. Same way, structured handovers are very, very important, because when we are going out, handing over once our shift is over, we say, okay, next dose of Pavan is at this time. We don't tell what is the background condition. So, structured handovers, or what is called SBAR format, is situation, background, assessment and recommendation. This is the type of standard handover should be done when you are handing over a patient. Suppose you are handing over a patient from theater to ICU, you should do a structured handover so that instructions are followed carefully. So what are the other systems approach? How to reduce the human error? This is what is called as Swiss cheese model, proposed by James Reason. All of you know, I think most of you know, that the holes on the Swiss cheese are at very odd and different levels. So to puncture through it, through all the holes, is not possible. All these act as barriers. So if you see these multiple slices, these are the barriers. Suppose a safety checklist, communication, equipment and drug monitoring, education training, these are the barriers to prevent the hazards. Okay? Our systems should be molded on this Swiss cheese model, where you have multiple levels of safety barriers before an event reaches a patient. That's where what is called as a safety Swiss cheese model. So, what are the foundations of safe anesthesia? Safety check, I have already spoken about safety checklists or SOPs, drug safety, device safety, use of simulators, use of black box data. Black box data is nothing but your trends in your monitor. Suppose an event happens, I always go back and see the trends. Did we miss anything on? Then reporting adverse events is very, very important. We have to create a culture of safety. Sometimes, apart from all the hi-fi stuff, a simple low-cost interventions like providing a magnifying lens at your drug loading trolley is going to avoid a lot of errors, because nowadays ampules are coming with such small size, nobody can see and read it properly. Suppose you provide one magnifying lens there or a calculator there to calculate the dose, because you cannot remember all the doses for all the patients. Same way, because our theaters most of the time are dark, we should have also a spotlight at the drug loading area and drug administration area. So, how to bring in the patient safety culture? Okay, we should build a safety culture. We should, as seniors, we should lead and support our staff. We should never punish them for reporting any errors. We should integrate our risk management activity. We should promote reporting. We should involve and communicate with the patients and public and learn and share the safety lessons. Suppose I have done some mistake, I have learned some lesson. I should teach, I should share. I should shamelessly tell that I have done a mistake. This is what has happened. Please don't do it. So we should implement solutions to prevent the harm. Coming to barriers, it is very easy to talk. But whenever you want to introduce something, there are always resistance. When I say we'll put the checklist, the staff will say, sir, we already have checklist. We don't have time to fill all this. We are already constrained. So there will be some resistance when you want to put in some safety measures. So that is where we have to involve them. We have to actually encourage them, and we should make them like clinical champions so that they will not come in the way of implementing the safety solution. Same way, whenever we ask for some, like I ask for a video laryngoscope, immediately my finance guy says, sir, we don't have in this budget. So that budget constraints also can be a barrier to safety. Same way, time I already spoke is we are all busy to get in something and to change, to implement safety protocols. We have time limitations, but we should work through it. Also, blame culture. We should never try to blame it on our juniors or somebody else. We should promote learning. From every incident, we should learn. We should learn. From every mistake, we should learn. We should not repeat that mistake. Okay, how to bring in perioperative safety culture? This is what I learned from a Japanese automobile company. They all follow what is called Kaizen. Kaizen is a Japanese word which is Kei means change and Zen means good, literally meaning change for better. This is implemented in Toyota, in Honda, in Nissan. All the Japanese companies, they implement in their safety and also in productivity Kaizen. What is Kaizen? Kaizen focuses on small changes. Kaizen emphasis on small incremental improvements rather than large disruptive changes. Because in a running setup, you can never put in a large disruptive change. You have to make it slowly and continuously. We should involve the employees. If you give top-down approach, it will never be followed. So we have to involve our team into the implementing the safety culture. Same way, Kaizen is a continuous process. It's not a one-time event. You do something today and forget about it. No. It has to be an ongoing process of identifying and addressing areas of improvement. And benefits, organization can benefit from improved safety, efficacy, efficiency, and overall productivity. So this is what is Kaizen. I think we all should implement in our operating rooms and ICUs, the Kaizen principles. To summarize, anesthesia factors are central to anesthesia safety. Errors are often systemic and not personal. Focus on training, environment, teamwork, and systems, and investing in human factors saves lives and improves outcomes. So what are the recent advances which happened in anesthesia last 2 decades which have enhanced anesthesia safety? Drug innovations like new drugs like liposomal bupivacaine, Sugammadex, all this further added to the patient safety. Advancements in anesthesia techniques like the target controlled infusions, ultrasound guided regional anesthesia, closed loop anesthesia systems, multimodal anesthesia, ERAS protocols, personalized anesthesia plans, multidisciplinary collaboration, and comprehensive anesthesia practice guidelines. All these have had a positive impact on the safety and comfort of the patient. So future developments, I think now many of our operation theatres have the surgical robots. I think it is only matter of time we will have the anesthesia robots. We can sit at home and give anesthesia. I'm hoping next 10 years it may happen. So, future developments, artificial intelligence in anesthesia, robotics, that is pharmacological robots, mechanical robots, genomics in anesthesia, augmented reality, virtual reality, Internet of Things, machine learning, all these are going to come into anesthesia. Artificial intelligence is development of computer systems that are capable of performing tasks that are normally require human intelligence. such as decision making, object detection, solving complex problems, and so on. Where all areas artificial intelligence can be applied in anesthesia: depth of anesthesia monitoring, control of anesthesia, event and risk prediction, ultrasound guidance, pain management, and operating room logistics. All these areas we can use the artificial intelligence. And coming to robotics, technological advancements have made robots integral part of several medical fields, including surgical fields. Mechanical robots automatically reproduce manual tasks, showing promising performance. Robots help in eliminating repetitive part of workload, allowing anesthetists to focus on the patients. Decision support systems, tele-anesthesia can improve clinical practice. Coming to pharmacological robots, it is a closed loop system. The data from the patient goes to the server, and then it adjusts the infusion pump to adjust the level of anesthesia. MedSleepy IV sedation machine is now available. People are using that, not in India, but it is available. It is designed to administer propofol, narcotics, and neuromuscular blockades. It controls hypnosis, analgesia, and muscle relaxation. Coming to pharmacological robots, the capillary intubation system. It is an intubating robot which has got an arm with a video laryngoscope. It will be able to place a tube into the patient. And dimensional surgical robots are also programmed to perform the regional anesthetic blockades. The Magellan robot can place a peripheral nerve blocks. All these applications someday may lead to performance of anesthesia by an anesthesiologist from a remote location. Thomas Emmerling, who is the father of robotic anesthesia, he says it is no more a realm of science fiction, and it is already on. So coming to genomics, last few slides. So pharmacogenetics is the identification of impact of genetic variants on drug dosage, response, metabolism, and safety. So pharmacogenic genomic testing before anesthesia can suggest the dose adjustments, detect responders, non-responder patients, and also predict the certain response. So by using genomics, we can personalize the anesthesia, personalized anesthesia plans, we can make it. So training and competency, whatever the machine, it is the man behind the machine is most important. So our training has to be a proper structured clinical education is important. We can't teach everything on patients, so simulation-based education plays an important role. We should all be up to date with practice guidelines and ongoing competency assessments. So this 10 commandments of safe anesthesia, actually this is not my own. Some forward has come in the WhatsApp, I have summarized here. Know your basics, physiology, pharmacology, or your spine. Dr. Phani always used to tell about to learn the basics. He was so strong in basics. I think all of us reading basics will be a tribute to him. Physiology, pharmacology, or your spine, master them. Pre-op is everything. So if you assess a patient pre-operatively properly, half of your job is done. Airway is sacred. Respect always the airway. Always have a plan B. Vigilance is survival. We all know our motto itself is eternal vigilance. Your eyes, ears, and sixth sense should never sleep. You should always anticipate and not reacting. We should think like a chess master, 3 steps ahead. We should respect the physiology because anesthesia, whatever said and done, is the breach in the controlled breach of the physiology. And a crisis is your moment. So all of us are heroes when everything is going on well. But in a crisis only our true character is exposed. That's where we should stay calm. We should lead the team. We should be the anchor. We should not run away, hand over the patient to run away. We should wait there. Crisis comes, but we should handle it properly. Communication is most important. This is the era of communication. Whoever communicates better will be leading the teams. Teamwork saves lives. So speak clearly to your team members. Never stop learning. Each case is a teacher. Each case we learn something. Dosage is dynamic. Tailor your drugs. No fixed dosages. So I summarized as ABC. A for assessment, anticipate, airway. B for basics. C for communication, checklist, crisis. D for dosage, documentation. E for eternal vigilance and education. So to conclude, given the complexity of modern day surgery, new issues will continue to challenge us, errors will still occur, but we can strive to design systems to reduce these risks, make anesthesia even safer. Blaming individual does not solve the problem, nor does it prevent future complications. Embracing a culture of safety, adopt the system-based approaches. Proactive identification and mitigation of potential hazards. Exceptional communication is important. Innovation, we should do in safe practices. We should be, all our seniors should be a mentor and role model. We should not compromise on the safety. Our juniors are going to learn all those shortcuts. We should never do that. We should be an example for them in role modeling the safe practices. We have to rethink our practices, adapt, improve, and redesign our tools. Safety begins with safe machines, safe processes, and safe environment. Prepare and prevent, and don't repair and repent. This is my take-home message. Zero future vision is our zero harm. Thank you all for giving me this opportunity and giving me a chance to speak to this august audience. Thank you all.